Tirupati. So he has a vast experience in orthopedics. So he started his career as assistant professor in our department in GADVASU, Ludhiana in 2002. Earlier it was PAU, and now like it's a GADVASU. So like he then shifted to Gannavaram as an associate professor and head in veterinary clinical complex department. And later on, now presently he's working as a professor at Tirupati. So he worked a lot on fracture fixation. So he's pioneer, I'll say, in intramedullary interlocking nailing, and I credit him that he has established orthopedics, especially intramedullary interlocking nailing in our department, Ludhiana. So I present in front of you Dr. M. Raghunath. Dr. M. Raghunath, I welcome you, and please start your presentation.
Thank you, Dr. Arun. Thank you for your welcome address. And the topic of this seminar assigned to me was Fundamentals of Fracture Fixation in Small Animals, a guide for undergraduate students. So keeping this in view, I mainly concentrated the talk on basics of fracture classification, because for an undergraduate, you should have a basic idea how to classify a fracture, what are different steps in classification of fractures, different types of fractures. And once you have a basic idea of fracture classification, then you can have an idea of how to fix these fractures with so many internal fixation devices that are available in veterinary practice today. And the majority of these devices or techniques or procedures have been adapted from human orthopedics since decades. And there are few techniques that have been developed and designed and developed for veterinary orthopedic purpose specifically. But majority of the implants or the procedures or the techniques, we have adapted them from human orthopedics. And we follow the same principles of human orthopedics in veterinary patients. But the difference, there is a lot of difference when you come to veterinary orthopedics compared to human orthopedics, because in human orthopedics, you have an advantage of bed rest, particularly for a locomotor function disorder. If a person is in hospitalized after a major surgery for a long bone fracture, and you ask him to lie down on a bed for 2 months, the patient will lie down for 3 months. But our patients, be it a small animal or a large animal, the moment our patient comes out of anesthesia, that particular animal will start ambulation. So that is a major difference between a human orthopedics and veterinary orthopedics. So as a veterinarian, you should have in mind that our patients are not possible to have what you call bed rest, which is a privilege for a human orthopedist. So keeping that in mind, you have to design your entire procedure of fracture fixation in such a way that post-surgery, whatever the forces that act on the fracture should be nullified to the minimum. Then only you can expect the outcome from your surgical procedure. So this is a basic background of veterinary orthopedics, and there's a lot of development in veterinary orthopedics today, and we are using the most advanced procedures, and the fractures are the conditions that were not amenable for internal fixation or for surgical procedure. We are now treating even such cases with a very good clinical outcome, and this is possible. You take it in small animal or you take it in large animal. This has become possible. Mainly, I will give credit to two innovations in veterinary surgery. Number one is anesthesia, and number two is imaging procedures. So anesthesia is critical. Earlier, the anesthetic protocols were not so advanced. We used to hesitate to anesthetize our veterinary patients, like a small animal or large animal or equine. And now, because of advancements in anesthesia and advancements in imaging, earlier there were no such imaging facilities to even at least diagnose the condition. But now we have SIAM facilities, we have large animal extensions, we have small animal extensions, we have computer-aided radiography, we have intraoperative image intensifying systems, and many of the colleges have come up with scan, MRI. So now imaging is now there is no point of missing a bone lesion in our patient. So that is advancements in imaging, and because of advancement in imaging, we can also visualize the healing process of the bone once you operate it for a long bone fracture. So these two advancements in anesthesia, coupled with imaging, have developed or resulted in the to take up advanced procedures in many patients with very good clinical outcome. So in this talk, I would mainly concentrate on uh, the different causes, fracture causes that will result in a particular fracture in certain patients. Number two, how to classify a fracture based upon the bone or area of the bone, the impact or the type of fracture that is resulted. Number three, we will be concentrating on few internal fixations because I was asked to, because it's an undergraduate talk, so I was asked to restrict to two internal fixation procedures. So I will be restricting myself to intramedullary devices, that too the earlier age intramedullary devices, and the modifications that have occurred in these intramedullary devices. And we will be also discussing on different types of plating procedures, bone plating procedures. What are the advancements that have taken place in bone plating procedures? The biomechanics of this bone plating procedure. So briefly, this will be the outline of my talk. So as we discussed earlier, every bone will undergo five different types of fracture forces if there is any trauma or fall from height. And these five different forces will result in one or other type of fractures. So these forces, we have classified them as bending forces. Bending is the one which acts on longitudinal axis of the bone, where the bone bends. Suppose the force acts on the bone on a longitudinal axis, the weak part of the bone will bend and will result in a particular fracture. Or there can be torsional forces. Torsional forces are nothing but rotational forces, where in longitudinal axis of the bone, one aspect of the bone will rotate in clockwise direction, the other aspect of the bone will rotate in anti-clockwise direction. This we call it as rotational forces that act and result in certain type of fractures. The third force that acts on a bone is axial compression. Compression is when the bone compress on its longitudinal axis, and this happens when, suppose when an animal falls from a height, animal lands on the ground with its paw touching on the ground. So the animal weight will be transferred to the ground, and equal and opposite reaction from the ground will act through the bone. So these two forces will compress with each other, one the weight of the animal and opposite ground reaction, and result in a force called axial compression. And this also leads to certain type of fractures. Now, other type of force that acts is the axial tension. Axial tension is when the opposite pull of the muscles. So tension is when there is a pull of in opposite direction because the muscle contracts when the animal falls from a height. That also leads to certain type of fracture. That is a tension force. And the last force that acts on bone is shearing. Shearing is always perpendicular to the long axis of the bone, where suppose this is the long axis of the bone, the shear forces act in a particular direction and result in second type of fracture. So these five forces are very important, and a majority of the times it is more than one force. It's a combination of, it can be a bending torsion, or it can be a torsion and shearing, or it can be a tension and bending. So it is always a combination of forces that will lead to the type of particular fracture. So as a veterinarian, whenever a case is presented for a fracture fixation, you take a preoperative X-ray, you see the type of fracture, and you should be in a position to make out what probable forces must have acted on this bone for such a type of fracture. What? Suppose you take a preoperative X-ray, you look at the X-ray, and all these five forces should come into mind, and you should be in a position to make out what probable forces must have created that particular type of fracture. So that is the reason why these forces are always being in your find such very bad fractures majority of times automobile accidents. They result in high energy trauma, and complete can be a complete or incomplete break in the continuity of the bone or a cartilage. This is how we describe a fracture, and it usually results in compromisation of locomotion, and locomotion compromise is a very pathetic situation in the life of an animal. And as a veterinarian or as an orthopedician, the primary goal of the fracture patient to treat the fracture patient should be to make the animal ambulate, to make the animal ambulate uh, at near normal anatomical position and a near normal physiological condition, and so that the animal walks on its four limbs as early as possible. And for that purpose, we have to do a very important position of fracture fixation. There can be associated soft tissue trauma, there can be loss of blood supply, there can be nerve damage, muscle damage, tendon damage, depending upon the energy that is resulted in the particular fracture. So, as I said, the classification of the fracture is important. We have to classify the fractures according. We usually classify according to 8 different categories, like biomechanics, as we have discussed what type of force must have created a particular type of fracture. Now you can classify a fracture based upon the anatomic location where actually the bone got fractured. That is again another type of classification. You can classify the fracture based on whether it is a closed fracture or an open fracture. Closed is the one where the bone fragments are not exposed to external environment, where the skin above the bone is intact. Whereas an open fracture is the one, open fracture is also called as a compound fracture, is the one where there is a loss of skin and there is exposure of the bone to outside environment, where we call it as an open fracture. This is how we classify based upon the extent of injury to the soft tissue. Next, we can also classify the fracture based upon configuration, what type of fracture it is, and we can classify whether it is a complete fracture or incomplete based on etiology. How whether it is an automobile, whether it is a fall from height, whether it is an abuse. Abuse means a hit by a owner, hit by an enemy of the owner. What can we call? We all put them under abuse to the animal. Now, stability, how stable the fracture fragment. There is a fracture, the fragments have separated, but how stable they are at the time of presentation. Based on that, we can classify. And how displaced the fracture fragments are. Whether they are lying very close to each other, whether they are spaced very far away from each other. Based upon that, we can classify. So, why classification is important is, if you classify the given fracture according to these 8 different categories, you will get a basic idea of what type of implant can be used in that particular case. So that will help you in deciding the treatment plan, number one. Number two, if those facilities are not available at your end, you can be in a position to refer it to a clinic or a college hospital where these facilities are available. For example, if it requires some advanced procedures, we can be in a position to directly refer them to a specialist or to a college hospital for a better treatment in terms of the fracture. The first category we take up the mechanics, that is the forces or the movements causing bone fractures. So this we categorically we have seen in the first slide. What are these forces like axial, tension, axial compression, torsion, bending, and shear forces? Now, firstly, these are the tensile forces. See, the tensile forces means tension forces which act in opposite direction. One direction of the force will be towards the ground. The opposite direction of the force will be away from the ground. And these are usually because of the contractures of the muscle. So these, because it is contractures of the muscle, these type of fractures are usually seen at the place where there is a lot of muscular attachments in the form of ligaments or the tendons. So, for example, in the whole limb, okay, one such area is the olecranon. This is the olecranon process. This is the humerus. These 2 paired bones are radius ulna. So, this is the fracture line, and this is the olecranon process. And olecranon process, this is the place where the very hard muscle, that is the plexus muscle of the caudal aspect of the arm, clear? So when there is an opposite pull of this transverse muscle, it will result in this type of force. So the force that is acting in such type of fractures is the tensile force, and the type of fracture you get if tensile forces are acted upon is avulsion. We call them as avulsion. Avulsion weak because it will happen according to the contraction of the muscle, and the fracture fragment move in the direction of the contraction of the muscle. So we call them as avulsion. So tension forces produces this elongation. Bone fails along the cement lines or osteons pull out, because particularly these are usually seen in young animals which are not where the skeletal maturity is not still under process. So mostly you get such fractures in these areas. Number one, greater trochanter in the case of femur. Number two, olecranon in case of radius ulna. And number three, tibial, anterior tibial tuberosity in case of tibia. So these are tensile forces, and type of fracture is avulsion. Now other type of fracture are compression. Compression is opposite to tension. Tension is in opposite direction. Compression is here both the here the ground reaction and the weight of the animal they compress, resulting in a fracture of the bone. So maximum stress in plane perpendicular to the load applied, and fracture propagates obliquely. Here the direction usually will be in oblique, and then compression fractures are usually seen in case of spine. This is a vertebral fracture where there is a compression fracture. See, there is an the fracture fragments are overriding over each other. So this type of fractures are seen in spine, and you also see such type of fractures in long bones also. Next, shear forces. Here we said that the act parallel to the bone surface, and bone is the weakest in shear forces. So suppose, for example, this is the shear. So the here in the long axis, if you take one fragment moves in this direction, the other fragment moves in this direction. So they slide over each other, resulting in a usually very long or oblique long fractures. So this is a lateral condylar humeral fracture. So this condyle got separated, and this fracture extending up to the diaphysis of the bone. So majority, if you find such long fracture lines, you should always suspect for shear forces. Now the other force is tensile force, and the tension forces that is generated on the convex surface. So every bone will have two surfaces. One is a convex surface, the other is a concave surface. Concave surface is a compressive surface. Convex surface is a tension surface. So they are generated usually on the convex surface. Now you can see this is the fracture line. This is the actual radiograph of radius ulna. So the tensile forces are generated on the convex surface. So sometimes there will be a combination of bending and compression, and resulting in a type of fracture. So bending forces, tensile forces generated on the convex surface, and compressive forces on the concave surface. So as I already discussed, bone will have, suppose you take a radius ulna. This side of the bone. So this side of the bone is always a compressive surface, and this side of the bone is a convex surface. Next is the torsional. The torsional we have discussed in the first slide that they are rotational forces. Rotation is, suppose if you take this as a single bone, and one segment of the bone will rotate in anti-clockwise, the other segment will rotate in clockwise. So because of these opposite rotational forces acting on a single piece of the bone, this will result in a very long oblique, usually oblique, long oblique, or spiral fracture. We always call them a S-shaped fracture. So it starts from here, and then S-shaped, alphabet S. So it goes all through the long axis of the bone, and it results in S-shaped or spiral. See the real picture in a tibia. This is a tibial fracture. The fracture line is starting from here. It is crossing the diaphysis of the tibia, and is also going on the other side of the tibia, resulting in an S-shape. Here a S-shape is because this fragment is rotating anti-clockwise, this fragment is rotating clockwise, resulting in a long oblique typical. So if you see a long oblique fracture on an X-ray, the first force which should come into your mind is torsional or rotational forces. Now we can classify the fractures based on anatomical location of fracture. So anatomical location, first you should, in your physical exam, in a clinical examination, the moment the case is presented for a fracture, you should first to go for a clinical examination where you palpate all the long bones that can be palpable and also the axial skeleton for involvement of the fracture. So in that clinical examination, you will come to a point that which bone of the body is affected. Now you have identified the bone that got involved. Now in that bone, based upon your clinical examination or palpation, you should be in a position to know whether it is an epiphyseal, metaphyseal, or like we'll see what are these epiphyseal, metaphyseal, and diaphyseal. Now, based upon your clinical examination, you should also be in a position to locate whether it is a condylar. If it is a condylar, is it intercondylar? Inter means between the condyles. I have shown you one X-ray of shear forces acting on humerus. That was intercondylar means between the condyles. Supracondylar means above the condyle. So whether it is condylar or trochanteric, that is trochanteric if it is trochanteric or subtrochanteric, or if it is a physeal fracture. And physeal fracture will have a separate type of classification. We will see that in diagrammatically. We call it a Sacker-Harris type of classification. So this is how you will localize the fracture. So this part of the characterization is localization of the lesion. Localization based on bone, localization based on part of bone, localization based on condylar or trochanteric or physeal fracture. Now this figure will clearly explain you the different areas of the bone where there is a possibility of a fracture. Suppose every bone will have two epiphyses. Suppose there is a fracture separating the epiphyses, we call it a epiphyseal fracture, and the next part of the bone is metaphysis. This is the junction between epiphysis and diaphysis. Suppose there is a fracture line here, we call it metaphysis, and from here, this is the entire structure, we will call it as diaphysis or cortical bone. And again, in the distal segment, you have same anatomical forms, that is a metaphysis and epiphysis. So epiphyseal fracture will occur here, metaphyseal fracture will occur here, diaphyseal fracture will occur up to this point. If it is proximal, it is proximal epiphysis, proximal metaphysis. If it is distal, it is distal epiphysis and distal metaphysis. So this is based upon the location of the fracture in a particular bone. Now we can see a few examples of this particular. You can see here, this is an epiphyseal fracture. This is the head of a humerus, where exactly the epiphyseal plate is got separated. Now this is a metaphyseal because this is the epiphyseal plate. Every epiphyseal plate will have a radial lucency on an X-ray if the animal is skeletally immature. You can see this radial lucency. Lucency means where there is no bony material. So this is an open epiphyseal plate. Again, this is an open epiphyseal plate, for this animal. Okay. Now this is not, the fracture is not like this exactly. In this bone there is an epiphyseal plate, but here the fracture has happened above the epiphysis. So this area we call it as metaphysis. Okay. So epiphyseal and metaphyseal fractures. Now this is a proximal. Now after epiphysis metaphysis, the remaining part is the diaphyseal. In diaphyseal again, we can divide the diaphyseal fracture as proximal 1/3, mid shaft, and distal 1/3 based upon the location of the fracture. So this example is of proximal 1/3 oblique fracture. Now this is a mid diaphyseal fracture, again an oblique fracture. Both are oblique fractures. This is in the proximal 1/3 of the bone. This is in the mid shaft of the bone. Now coming to the next type, this is distal 1/3 of the femur fracture. You can see a very badly fractured femur with the distal 1/3 of the bone. And there is space, there is no overriding, and you can also see many bony chips that are present at the fracture site. So this, according to the area of the bone, we can classify this as a distal 1/3. We have seen the proximal 1/3, mid diaphyseal, and distal 1/3. And if it involves the articular surface is the one where two different joint forming bones attach with each other. So this you can see here, this is an acetabulum. This acetabulum forms a joint with the head of the femur. So the acetabular joint surface and femoral head joint surface will form the articulation here. So because there is an articular fracture, these are classified under articular fractures. Now this is, so we have seen condylar and supra. Supra means above this. This is the condyle of the femur. So this is the proximal fragment of the femur. This is the fibia. So the fracture has occurred here and this is displaced. So this is supracondylar. Again, this is supracondylar humerus fracture, and this is supracondylar plus intercondylar. You can see there is a separation between two condyles of the humerus. This is an elbow joint. This entire thing is an elbow joint. So you can see two condyles of the femur getting separate. So we can classify it as an intercondylar or intracondylar. Now, based upon the involvement of the epiphyseal plate, there is a separate classification given by Salter Harris, and this is very important for a preoperative examination and preoperative X-ray, so that you can plan your treatment option based upon the Salter Harris classification. So, in the Salter Harris classification, there are 5 different categories based upon the direction of the fracture line. So keep this in mind. This is very important. Direction of the fracture line, where actually the fracture line is traveling. If it is traveling along the faces, say as I said, in young animal, the growth plate is always open because it is not skeletally mature. So the growth plate is a common area where you find fractures in young animal. So Salter Harris, if the fracture line is directed along the faces, we call it as a type 1 Salter Harris. And if the fracture line is traveling along the facies, but it is also involving the metaphysis, the direction here, it is going towards the metaphysis. So we classify it as type 2. And if the fracture line is traveling along the facies and it is going towards the condylar area, towards the epiphysis, then we classify it as type 3. And in type 4, the fracture line travels through the facies, through the epiphysis, and also metaphysis. See here, it is coming through the facies, it is going into the epiphysis, and it is also going towards the metaphysis. So this is we classify as Salter Harris type 4 classification. And in type 5, there is a compression along the epiphyseal plate. There is no displacement. Whereas in type 1, there is a fracture line along the epiphysis, and there is a slipped epiphysis. So 1 and 5, here it is a compressive force both acting on the epiphyseal plate. So this is 1, 2, 3, 4, 5 classification for a Salter Harris type of classification. So this model of a bone will clearly tell you about the type 1 Salter Harris, and this X-ray will clearly tell you what a type 1 slipped capital epiphysis. So exactly in the epiphyseal line, the fracture got, the head of the femur got separated, and you can see this is the normal position, and this is how a type 1 Salter Harris will look like, and on X-ray it will look like this. Okay, so these classification will always help you to plan your treatment options. Now this we have seen, when if it travels up to metaphysis, we classify under type 2 Salter Harris. Now we have seen a schematic diagram. Now we are seeing real X-rays how a type 2 will look like. So here, not only the epiphyseal plate, it is also going up to the metaphysis. Again, a type 2, see the epiphyseal plate coming down, because this is a proximal end of a bone. So it is coming down through the metaphysis and physis. So we type this is a type 2 Salter Harris classification. And compression fracture we have seen in type 5, where there will be compression at the fracture site along the physeal plate. Now coming to the communication with environment. So this also we have studied how to classify whether the bone is communicating with external environment, whether the bone is not communicating with external environment. If it is communicating, then there must be a damage to the soft tissue, and the skin also must have got opened up in case of open fractures. Whereas if it is not communicating, then it means the skin is intact. There is no damage to the skin. So it depends on mechanism of puncture and the severity of the soft tissue trauma. So majority of times what happens when there is a fracture, and if this fracture is having a very sharp ends of either of the fragments means whether it is a proximal fragment or a distal fragment, the sharp end during the time of concussion or during the time of trauma will penetrate the soft tissue, and it will sometimes also can penetrate the skin itself, resulting in a open fracture. Okay, so the closed and open fracture, there is a lot of difference in the outcome of the case. So open fractures, closed fracture, there is no damage, bone is not exposed to environment, so there is no chances of infection, there is no chances of osteomyelitis, so the chances of recovery are more. Whereas if it comes to open fracture, where the bone is an exposed to environment, where there is a lot of soft tissue damage, where there is a skin penetration and the bone is getting exposed to environment, naturally all the environmental pathogens will enter through the skin opening into the bone, and once it enters into the bone, it will enter into the medullary canal, and there are chances of getting osteomyelitis even before surgery or also after surgery. So such fractures, open fractures, will have a very guarded prognosis. So treating a closed fracture, treating an open fracture, you should inform to the owner before attempting the repair that this is an open fracture. This will have these 1, 2, 3, 4 complications, and the prognosis will be always guarded. So because owner should be prepared for the eventually for the post-operative complications. So now this is a pelvic fracture, and because pelvis is a very secured area, there are little chances of open fracture here. And whereas extremities, so for example, radiocarpal fracture or metacarpal fracture or carpal fracture or distal radius fracture, they are covered with very little musculature. These are all classified under distal limb fractures because there is a little cushioning here because of softness, less soft tissue around these bones. They are more prone for open fracture. So, for example, this is an open radiocarpal fracture. Now, this is how schematically, see the long bone here, from here to here, this is the femur bone. The fracture is at the level of the mid diaphragm space. As I said, either of the fragments will have sharp edges. Here, both the fragments are having sharp edges. So, one of the sharp edges of the proximal fragment has penetrated this complete musculature and also the skin, exiting the bone through the skin. So, this we can classify as open fracture, and this will definitely have a guarded prognosis. So based upon the type of open fracture, we can classify them as grade 1, 2, 3. And grade 1 is when the bone breaks the skin from inside out. Okay, so it is because of the penetration of the sharp edge of the bone, there is an open fracture. And in grade 2, the wound is less than 1 centimeter. This is caused by external force. Okay, so sometimes not necessarily that all fractures will have this such short times, and not necessarily that all bones should penetrate out. Even the compound fracture can also result because of external force. For example, in grade 2, it is not because of penetration of the bone, it is because of the external force, and here the wound is less than 1 centimeter. Whereas in grade 3, there is a very large wound because of external force, and there is a fracture. There is also loss of soft tissue. So this is where the wound is large, we classify it as a grade 3 open fracture. Now see, I am showing you the X-rays and also the gross picture of these fractures. The very high energy trauma. Here you can see the distal radius ulna fracture, severely comminuted radius ulna, and also metacarpal fractures. So these metacarpal bones are exposed here because it is a degloving injury. We call them a degloving. Degloving means as you remove your gloves, you wear a glove and remove your glove. So like that, the soft tissue will be sloughed off because of roadside accidents, and you can see exposed in metacarpals, a lot of abrasions. And this animal, you can see the X-ray here. Again, a distal radius ulna, very severely comminuted distal radius ulna, and all 5 metacarpal bones got fractured. So you can see the fractured, exposed metacarpal bones. All 5 metacarpal bones got damaged, and there is also a lot of soft tissue damage. coming to gunshots. Gunshot means because of abuse or accidentally someone fires on the animal. All gunshots are always open fractures because the bullet is entering from outside and it is hitting the bone and it results in an open fracture. We always consider them as open fractures. Now coming to the direction of the fracture line, how the fracture line is traveling in a bone, based on that we can classify the fracture like, for example, the first one is the transverse fracture, next is an oblique fracture. In oblique also we have a very short oblique or a long oblique. Long oblique we have seen earlier, they are also called spiral fractures. Okay, and the segmental means if it have two a different fracture lines. We'll see in X-ray how a segmental fracture will look like. Same bone, single bone will have two different fracture lines which are not communicating with each other. Whereas a comminuted fracture also have two fracture lines, but they communicate with each other. Then we call it as a comminuted fracture. If a bone have two fracture lines, but they do not communicate with each other, we call it as segmental or multiple fractures. Now we have an impaction and fracture dislocation means there is a fracture. Mostly they happen at the very close area to the joint, and the fracture will also be associated with the dislocation. Then we call it as a fracture dislocation. And avulsion. Avulsion in the earlier slides we have seen, avulsion are always because of tensile forces, and they always result by because of tension of the muscle pull. So these are avulsion fractures. Now coming to the direction of fracture line. Now just looking at the X-ray, everyone can tell that this is a simple see the fracture line is traveling along the cortex of the bone, and as if someone has created this structure. So this is a very two-piece bone. So this is a proximal fragment, this is a distal fragment, two-piece bone, and the fracture line is running across the bone. So this is a simple transverse fracture. Now this is again a bifacial fracture, but the fracture line is covering from this end of the bone up to this surface. That means this is a spiral fracture. So very long oblique fracture, we call it as a spiral. Now just by seeing this fracture, you should immediately one thing should come in your mind is the type of force. So in a spiral fracture we have discussed. So most probably the type of force acting on this fracture is rotational forces. Okay. Now again a short oblique. Earlier case we have seen a spiral. It is an oblique fracture, but it is a very short. And if it is covering a major length of the bone, then we call it as a long oblique, or sometimes also called as spiral. See how much length of the bone this is covering. So this is a long oblique fracture. Now comminuted means if it is having more than one fracture line. So these comminuted fracture line, in comminuted they meet with each other, they communicate with each other. So that we call it as a comminuted, and usually it results in formation of bone chips or bone segments. And there will be two major fragments. Apart from major fragments, you have these comminuted wedge-shaped chips. We call them as comminuted fracture. And in a single bone, there are more than one fracture line communicating with each other, resulting in formation of small bone fragments or wedge fragments. We call it as a comminuted fracture. Again, the same classification. If there are more than two fracture lines in the same bone, but they are not communicating with each other, that we call it as segmental fracture. Why segmental means the bone is divided into different segments. So see here, this is a single femur bone. There are two fracture lines. One fracture line is here, okay. The other fracture line is here. So they are not communicating with each other. That resulted in formation of segments of the bone. This is one segment, this is the other segment, and this is the third segment. So the bone is divided into three segments. So this we call it as segmental fracture or multiple fracture. Now impaction, when it occurs at the distal epiphyseal area, we call it an impacted fracture. There is also the ulnar fracture here. You can see here the fracture line. And if the fracture there is a suppose this is a tibial bone and this is a fibular bone. There is a fracture at the distal end of the fibula. In addition to the fracture, there is also dislocation of the tibia from the tarsal bone. So this is tibio-tarsal dislocation in addition with fracture of the fibula. So we can classify this as a fracture luxation or fracture dislocation. Okay. Now avulsion, this we have seen in earlier also when we were discussing about the fracture forces. We have discussed what type of forces. So avulsion is when there is a pull on the attachment of the muscle over the bone, it will result in avulsion. And the movement of the fracture fragment will be in the direction of the muscle pull. So here, schematically, let me show you this figure. So this is distal femur, this is proximal tibia, this is the patella, and this is the quadriceps group of muscle that will travel over the patella. This is the patellar ligament, and this will attach over the anterior tibial tuberosity. This is anterior tibial tuberosity. Now, by suddenly, if the animal contracts this quadriceps muscle, this patellar ligament will pull the anterior tibial tuberosity in such a way that it gets separated from the parent bone and results in avulsion of a fracture. So this is how usually it is seen in any animal, and usually the main etiology for such type of fractures is fall from height. When the animal lands on the ground, there will be opposite pull of the muscle contracture resulting in such type of avulsion fractures. Now coming to severity, whether it is a complete fracture, and if it is a complete fracture, whether it is a two-piece fracture or a three-piece fracture, or it is having very small butterfly fragments. Very small butterfly fragments means small chips that have resulted because of comminuted fracture. And whether it is a complete or incomplete. Incomplete means where the fracture is not complete, we also call them as green stick fracture. The green stick means why this name is given. Suppose you take a branch of a tree directly from a tree and you try to break the branch. So it will break, but it will break only on one surface. The other surface will be intact. So that we call it as a green stick. Whereas you take a dry stick, okay, very completely dry stick and break it, it will break on both the surfaces and you will get two different pieces. So green stick fractures are always called as incomplete fractures. So best example is between a complete and incomplete. Incomplete or a green stick. You see here, you can see the faint fracture line here. It is involving only this cortex, whereas this other cortex is. Whereas a complete fracture, both the cortices are involved, and it is a complete fracture. So green stick fracture or incomplete fracture, complete. Now another classification to classify all the time the fracture may not be because of external trauma or fall from height or hit by somebody. So there can be fracture because of pathological fractures. Pathological means suppose probably there is a bone cyst uh, that is there in the bone resulting in fracture, or there can be a bone tumor, or there can be severe osteopenia. Osteopenia means generalized reduction in the mineral content of the bone. So such conditions will also lead to certain fractures, like this is a pathological fracture because of a bone tumor. This is a pathological fracture because of a very thin cortices, very thin cortices. The even small fall from one step or fall from a sofa or cot will also result to fracture in such conditions. So we classify them under pathological fractures. Now we can also classify them how stable the fragments are. The fragments means the proximal fragment and distal fragment. So when you take an X-ray, preoperative X-ray, how stable they are. Suppose you take this fracture, it is an interdistal fracture, and the fracture fragments are lying close to each other. They are facing each other. There is no much displacement. There is no much deviation. So they are stable fracture. It can classify as stable. You take the same radiograph. You take this particular day where there are multiple. You cannot count the number of pieces of this bone. So this is a tibial bone. You can see the fibular fracture. Tibia, this shaft of this particular part of the tibia is involved in a lot of bone chips. There are many fracture lines. So this we cannot classify as a stable fracture. So this is classified as stable. This is classified as highly unstable fracture. Now, based upon displacement of one segment relative to the another segment. Okay, we have seen that if there is a fracture, there will be two segments. One is a proximal segment, other is a distal segment. And how these fragments are displaced in comparison to each other. Based on that, we can say, so suppose this is fracture, this is a distal segment described relative to the proximal, it is displaced fracture. Whereas if you take this fracture, both proximal and the distal are lying very close to each other. So not that much displaced compared to this fracture. So based upon the displacement, we can classify. So close the long oblique fracture of the proximal tibia diabasis, one can compare between displaced and not so displaced fractures. So this is basically how we can classify the articular fractures, the epiphyseal fractures, metaphyseal fractures, the diaphyseal fractures, based upon the line, the direction of the fracture line, number of fracture lines, whether the fracture lines are communicating with each other or not. So this is how now you get a complete comprehensive idea of how to classify, how to localize the fracture, to which bone actually, from bone, which part of the bone, from part of the bone, which direction, and how displaced it is, how separately the fracture edges are lying. So now we got a comprehensive idea. If it is an articular fracture, whether you can classify as a Salter-Harris type of fracture, 1, 2, 3, 4, 5. So this is basically how we basically classify the fracture, whether it is open, closed, if it is open, grade 1, grade 2, grade 3. So now we got a basic idea. So the basic idea to have this vast classification talk is you should keep this in mind for the future treatment protocol. So closed versus open, you should have a different treatment protocol. Transverse and oblique, you should have a different treatment protocol. Because the implant you are using should be in a position to counteract these forces that are acting on a particular. So coming to the internal fixation, what are the principles of internal fixation? Principles of internal fixation are the goals of fracture. Any fracture scale, whether it is an axial skeleton or a pendular skeleton, it should be an atraumatic technique. Already the animal has undergone a lot of trauma. That is the reason why there is a fracture in that particular animal. So the further, when whatever the technique you are adopting, whatever internal fixation procedure you are adopting, it should be minimally traumatic. It should cause minimal trauma to the number one. Number two, you should get back a near normal anatomical reduction. Reduction means, see, as we have discussed earlier, all fracture fragments will not lie close to each other or opposite to each other, because depending upon the impact of the trauma, the most of the time the fracture fragments will be displaced. So you should bring them back to a normal anatomical position. Whenever you are applying any internal fixation, they should come back to normal anatomical position. We call it as reduction. This is the reduction means you are bringing them back to normal anatomical position. Then after that, it should have a stable fixation. So the stable fixation means as long as the bone heals completely, because usually the healing time of bone is long compared to a soft tissue. Suppose there is a cut on your skin, it will heal by primary intention or secondary intention or scar formation within 2 weeks or maximum 3 weeks, because it is soft tissue. And soft tissue injury, suppose skin it is damaged, it is never replaced by skin. Skin damage, which is replaced by a scar tissue. Whereas a bone is the only tissue in the body which will be replaced by the same tissue. Suppose bone is fractured, it is replaced by bone itself. So for the bone to be replaced, it will take prolonged period of time compared to a soft tissue. So bone healing usually, depending upon the age of the animal and many other factors, usually we take it at 6 to 8 weeks maximum. That is 6 to 8 weeks. Again, it may prolong depending upon the conditions. There are so many conditions that affect the fracture healing. So usually we take a standard time of 6 to 8 weeks for the bone to heal. So for that period of 6 to 8 weeks, the implant or the fixation device you are using should hold the fragments in that particular anatomical position as long as it is complete healing. So reduction is important. Reduction means you are bringing back the fracture fragments to normal position, and fixation is also important, where we are fixing the fracture until that time when the bone completely fixed. And our other goal of fracture is early return to full function. Suppose you have operated today and your fixation is very good, your implant is very good, your reduction is very good, your soft tissue handling is very good, and then the animal should walk by a second day or third day. Okay, so this is the major goal for an orthopedician, that my patient should walk as early as possible, so that the locomotion of the animal is not affected. Now, coming to the other things, now we have decided, you have seen the X-ray, you have localized the lesion, you have classified the fracture. Now you have two options for the repair of the fracture. One is open reduction. Open means surgical exposure. You are opening the site of fracture and we are fixing the fracture. Usually we do it by internal fixation. The other option is closed reduction. Closed means we are not opening the fracture site. We are not surgically going up to the fracture site. So we are managing the fracture with the help of external fixation. We also call it as a coarctation procedure, by using certain bandaging procedures, by using certain springs, by using certain wooden springs, by using certain aluminum springs or iron springs or plastic springs, and using certain cast like plaster of Paris or fiberglass cast, we are managing the fracture. This way, all together they are put under coaptation procedures. Okay, when you get a good imaging procedure, when you know the fracture classification, immediately the surgeon can take a decision whether I should go for a closed reduction or for an open reduction. Now, what are the advantages of internal fixation? Internal fixation means we are going up to the fracture site, we are going surgically, we are opening it, and we are going up to the fracture site. Other advantages of internal fixation are we are visualizing the fracture site. Okay, seeing an X-ray is different, seeing actual fracture site is different. Okay, sometimes X-ray may mislead you. X-ray may show you a two-piece fracture. When you open up, you may find a third piece also. So grossly, intraoperatively, when you go and you visualize the fracture site, you get a complete basic idea of what type of fixation should be used. So when you are opening the fracture site and you are using an implant is nothing but a device that will help you to attain the fracture healing. So implant can be many types. It can be a simple wire, it can be a simple screw, it can be an intermediate, it can be more than one intermediate, it can be a K wire. We will see in the meanwhile in the further slides, we will see these different types of implants. And we are fixing the fracture using these implants. And the advantage of internal fixation is it will allow weight bearing during the process of healing. As I said, usually we take 6 to 8 weeks as a fracture healing time, but you cannot expect the animal to walk on 3 limbs until 8 weeks. No, but our idea is to use the operated limb also as early as possible without damaging to the reduction you have done. Reduction means you have brought back the fracture fragments to normal position, and you have maintained that normal position using some of one or the other implant. And during the process of healing of the 8 weeks, the implant should not be disturbed, the fracture site should not be disturbed, but animal should walk. That is the criteria for an orthopedic. Okay, health of the limb and joints, increase the circulation, it should promote the healing, and it should not have an extensive care, because as I said, our veterinary orthopedic patients, it is not possible to provide such a care as a human orthopedic patient. So the technique you have used should not require an extensive post-operative. Now, disadvantage, there are always, but any fixation will have advantages and disadvantages. Disadvantages are invasion. Invasion means you are invading into the tissues of an animal. You are invading at the fracture site. There is a chances of slow healing because you will be disturbing the fracture site there. You will be disturbing the soft tissues. But we are disturbing for the benefit of the animal to have a rigid fixation. There are chances of infection. Suppose your theater is not sterilized, your instruments are not sterilized, your implant is not sterilized, the surgeon himself is not properly scrubbed or followed the sterilization procedures, there is every chance that uh, lead, you may make the tissues infected. Okay? So the longer the procedure, the chances of more infection. Okay? And second is the cost. When you are opening a fracture site, that means you are opening it under an anesthesia. So cost of anesthesia. Okay. Then the cost of operative procedure and the cost of implant. Implant nowadays are becoming very costly because even in veterinary we are using very highly advanced implants like titanium implants, which are very costly because of the advantages of that material. So the cost you should, beforehand you should inform the owner about the drawbacks, the cost involved, the time involved, the recovery time involved, and the care to be adopted by the owner at the house. You should also discuss this with the owner. Now, what are the factors affecting the fractures? Factors affecting fractures. The type of fracture, the anatomical area, whether it is an articular area or the facial area, how badly the soft tissue is damaged, and how long there is the fracture has occurred. So these are all affect the fracture, like animal age, weight of the animal, temperament of the animal, owner finance of the owner, aftercare of the animal, equipment, and even surgeon's experience. So you should never attempt a procedure which you are not thoroughly aware of. Okay, suppose you can do if you are confident on doing one type of procedure, you should adopt that particular procedure where you are confidently able to do it. Otherwise, there is always a chance, or you can refer it to a referral hospital or a college hospital where there are advantage of equipment and experience. Okay, never attempt a new procedure because you will be affecting the life of the animal. Now, coming to the different types of implants that you are usually used, that you can use for fixation of fracture. So the basic equipment, the basic thing is orthopedic wire. They are nothing but made up of stainless steel wire, and they come in different sizes like 20, 22, 24, 26. So depending upon the size of the animal, the weight of the animal, you can select these stainless steel orthopedic wire, and they are made of stainless steel. And usually they are never used as a primary fixation procedure. Primary fixation means the one which gives the basic stability to the fracture segments. Okay, they are always, these wires are always used as a secondary or ancillary fixation. Ancillary means suppose you do an intermediary pinning. Along with pinning, you can use it. Okay, suppose you do a tension band wiring. Along with the K wires, you can use a orthopedic wire. Suppose you do an iron. Along with the interlocking nailing. So as an ancillary extra support, the wires can be usually used. Okay, now these are few examples where the surplus wire is used as ancillary. So suppose this is a fracture. The basic implant here is the intramedullary thing. Apart from this thing, the surplus wire is used as 1, 2, 3, 4, 5, 6, and 8 full surplus wires. So probably this is a very long shattered fracture. So that is the reason why it is used along with a primary implant. Primary implant here is intramedullary, or if full surplus is the one which goes all around the apex of the bone, we call it a full surplus. Or if you drill a hole through the one of the fragments and without going all through the bone, if you only go through the holes of the drilled holes of the bone, we call it a hemi. Hemi means half. Only half of the bone is covered. We call it a hemi surplus. And if the wire can also be used as a tension band, here you can see along with the K wires. We will discuss this procedure in further slides. So it can also be used as a tension band, or the wire can also be used. Suppose this is a mandibular fracture. This is the fracture line. This is used as interfragmentary device. So this is used as interfragmentary device. So two wires are used for the repair of the mandibular fracture. Now, types of full circular, how suppose you do a circular wiring, how a knot should be placed. So, knot it depends on the choice of the surgeon. Different surgeons use different knots. So, this is one method of securing a circular wire, that is nothing but using a
twisting. Just to twist both the ends of the stainless steel wire. This is one method. The other method is you make a loop here of one end of the wire, and you take the other end through the loop and just twist the wire. This is another method of securing. The other third method is you make a loop of the wire and insert the other ends of the loop and then bring them back and press it again. So this is the third method. So majority of the surgeons use this twisting method to secure the circular. Now, what are the principles of full circular wire placement? Then mostly when you want to use a full circular, the fracture should be a long oblique fracture. Okay, a bone should be anatomically reconstructed. You have to select an appropriate size of the circular wire, and never use a single circular wire. Which you should keep in mind. On a bone, never use a single, because if you use a single circular wire, it will act as a fulcrum. Okay, it will act as a fulcrum. It will lead to more damage than good to the bone. So always we should use at least two circular wires, that is 1 centimeter apart from each other and 0.5 centimeter away. Okay. So principles of full circular, and so this is how a bone and different forces acting on the bone. And do not entrap soft tissues. So when you're taking a full circular wire, you should take proper care that your wire is passing around the bone and it is not involving any muscle tear or any ligament or a tendon or a muscle. Because what happens if you do it over the soft tissue and if you tighten the wire, that soft tissue will undergo avascular necrosis. Suppose you have done it over a muscle fiber. The wiring you have done over the muscle fiber without separating the muscle fiber, you have done along with the muscle fiber, entrapping a soft tissue. Then that particular muscle will undergo avascular, because tightening the screw, tightening the wire, it will undergo avascular necrosis. So that muscle will undergo atrophy, completely necrosis. So in meanwhile, what happens? And a couple of days after, the wire becomes loose because that muscle fiber which you have included is necrosed. So the wire becomes loose and it will not give stability to the fracture. Okay, don't entrap soft tissue. Always place perpendicular to the direction of the flow. The wire should always be perpendicular. Okay, and lock wire where there is a change in bone diameter that we discussed. Wire should be tightened enough and do not bend ends over. So as I said in the earlier slide, you have to do a knot or you have to twist it. Okay. So securing twisted wires, you can use a plier, wire tighteners or pliers, and you can use a single or a double loop wire. I have shown the figures of here. Okay, and you get these special wire tightening devices here. See, so this is the long axis of a bone, which we have shown on a cadaver bone. This is the long axis of the bone. So this wire is going all around the surface of the bone. So this is a circular wire. Okay. Now using this wire tightener and see the direction. This is the long axis of the bone, and we are putting the wire in perpendicular direction. So always wire should be placed in perpendicular direction. And using this, we are twisting the wire. So this is how the wire should go loop by loop, and it should be twisted on long axis. So this is a good method of doing the full circular wire, and this should not be one end of the wire is straight, the other one end is only twisting. So this is a bad method of doing the circular. Okay, keep in mind that never use a single wire. Always use more than one, a minimum two. Number two, it should always be no soft tissue should be entrapped. It should always be perpendicular to the long axis, and the securing it should be always good. Now after wires, the other fixation procedures are simple intramedullary fixation. Intramedullary means within the medullary canal. We are putting a device inside the medullary canal. Medullary canal is the cavity of a bone surrounded by the cartilage. Okay. We are putting a device inside the medullary canal. So that is the reason why we call it intramedullary fixation. And what are these types? There are simple intramedullary pinion, there is a K-wire pinion, there is a rush pinion, there is a cross pinion, and there is also a procedure called intramedullary cross pinion. So here we are putting a device in the medullary canal neutral axis of the bone to provide stability until the fracture heals by callus formation. Okay. So this is intramedullary fixation. So it is very resistant to bending forces. So we have studied long back on the slides what are these forces. And bending force is one force, a very destructive force. So that has to be counteracted by the implant you have used. Suppose you are using a intramedullary pin, and because we are putting this intramedullary pin in the medullary canal, that is in the neutral axis of the bone, it will counteract the bending forces very effectively. That is the advantage of the intramedullary pin. And you require a very little equipment to do this procedure. It is very easy to remove. It causes very little damage to the blood supply. Inexpensive, you get a simple intramedullary pin by 100, 150 rupees. They are available everywhere. You can do it by both closed and open method. Closed means without opening the fracture site, you can insert the pin by reducing fracture, or you can go open the fracture site, visualize the fracture, reduce the fracture, and do an intramedullary pin. Okay. Now, so this is a schematic diagram where we are seeing that a bone, this is the fracture line here, and a intramedullary pin is inside this bone to stabilize the fracture. So fracture is reduced to normal anatomical position, and the pin is placed inside the bone. Now, we have studied the advantages that the intramedullary pin can counteract the bending forces. Now, this bone, because there is a pin inside the medullary canal, it is difficult to bend. Okay, that is the stability that is provided by the intramedullary. But this pin cannot stop the rotational forces or torsional forces, because even now when the animal starts walking after this procedure, there is every chance that upper fragment can move in clockwise and this lower fragment can move in opposite direction, and they can cause a rotational instability. Okay, they are poor in counteracting the rotational instability. Okay, so rotation, they do not counteract rotational forces. Okay, for that you have to use additional fixation like that. Okay, they provide endosteal tab. What we are doing here is this is the medullary canal. We are filling this medullary canal with another structure which is round in cross section, and it will have certain contact between the bone. At least 70%. Suppose this is the diameter of the bone. You have to select a pin of diameter at least 70% of the medullary canal diameter. Okay. Suppose a dog has come with a 10 millimeter medullary canal. So you have to select a pin which at least have 7 mm size. Okay. So that 70% of the medullary canal is filled by the pin. Or we can use another procedure called stacked pinning. Stacking is putting stacking something in the medullary canal. What you are stacking? You are stacking intramedullary. So that we call it as stacked. We will see further. So as I said, suppose this is a fracture line here, very bad fracture, and you have put a intramedullary pin in the medullary canal of the femur. Now, because it is a comminuted fracture, comminuted means we have discussed that we have more than one fracture and communicate with each other. So when the animal starts walking, so these forces will act at the fracture site, and because this is a simple intramedullary pin, it cannot withstand the axial compression forces, and there is every possibility that the fragment will collapse over each other. See here, earlier, immediately after post-surgery, there is a lot of gap between the two major fragments. Now, because the pin failed to withstand the axial forces, that gap has got reduced here, and that means there is a collapse of the fracture site. We call it as telescoping of the fracture site. And because of this telescoping of the fractures, the implant has moved away from the one end of the bone. See earlier, during immediately after surgery, only this much implant was exposed outside the bone. Now, because there is a collapse at the fracture site, this much bone, pin got exposed outside the bone. This is because of collapse at the fracture site, because they cannot withstand the axial forces. Now, these Tiemann pins are available in different sizes, that is based on the diameter. They are also available in different lengths. Okay, and what you can do is you can select a pin and whatever length you want, you can put. The extra length of the pin can be cut snugly to the bone. Okay, with the help of a pin cutter. Now these pins, they come in different sizes, lengths, and also the ends. End of the pin also. They, for example, this is a chisel end pin, this is a trocar end pin, and this is a trocar end with a thread scissor, the distal end of the pin. Threaded pin means it will provide more stability when you put this in the distal end of the bone. Okay. So these different ends of the pins are available. What you require to insert the pin. So this is, we call it as a Jacob's check. Okay. So this is key to open this Jacob's check, and you can introduce the pin into the Jacob's check, and by rotational force movements, you can introduce the pin to the bone. Or if you can have, if you do not have a Jacob's check, you can also use a battery operated bone drill, because the function is same. Even in the bone drill, you can insert the pin and you can do the intermediate pin. And there are two different methods of doing a intermediate pin. We call them as the retrograde and normograde. Retro, as the name indicates, retro means back. So we are entering from the back of the fracture. Normo means from the normal surface of the bone. Now see, this is a difference between a retrograde and a normograde. Suppose this is the fracture. Okay, this is a, you can call it as a metaphyseal fracture of the humerus. This is the fracture line. This fragment goes separated. All you can do is, this is a retrograde. So this is the fracture line. We are introducing the pin, okay, from the fracture line into the proximal fragment. Then it will exit away from the fracture proximal fragment. Okay. Now you shift the Jacob's check from here to here, and we withdraw the pin up to the fracture line. Now we reduce the distal fragment here. We put it into the near normal anatomical position, and from here we are driving this pin crossing the fracture line into the distal line. Okay, this we call it as a retrograde intramedullary pinch, because we are entering from the fracture side. Okay, we are entering from the fracture side. This is called retrograde. Normograde means the pin is always inserted at the epiphysis and driven across the fracture. Now see here, the femur. This is how. So every bone will have one point of entry. Point of entry means there is an anatomical location for every bone, and through that anatomical location only you have to enter into the bone. Okay, that we call it as entry point of a particular bone. For example, if you take a femur, the entry point for the femur is in this trochanteric fossa. This is trochanteric fossa. So if you say, if you take the anatomy of the femur, this is the medial aspect of the femur where there is a femoral head, and this is the lateral aspect of the femur where there is a greater trochanter. Between these two, there is a fossa. You can see here, this fossa. This we call it as trochanteric fossa or intertrochanteric fossa, and we have to drive the pin into the femur through this trochanteric fossa only. Then only you will exactly enter the center of the medullary canal. Okay, so this is the entry point of the femur. And for a femur, you can either do a retrograde or a normograde. Okay, and direct laterally, and you can reduce the fracture and put the pin into the distal fragment. Now for tibia, see, this is tibial bone. Tibia, because it is very closely associated with the stipes joint, usually it is preferred to do a normograde pinning in tibia. Okay, suppose you do a retrograde, suppose there is a fracture line here, you do a retrograde pinning, there is every possibility that you will be damaging the structure. So to avoid that, it is always better to go for a normograde. So this is the point of entry for the, this is articular surface. Okay, this is the entry point for the tibia to enter into the bone. In humerus, again, either you can do a retrograde or a normograde. The entry point for the humerus is the greater tubercle on the lateral aspect. So this is the humerus. This is the medial aspect of the humerus. This is the humeral head. This is the articular surface, and this is the greater tubercle of the humerus. So lateral aspect of the greater tubercle of the humerus is the entry point for the humerus go towards the medial condyle of the humerus. So this is the medial side of the humerus. The pin should always be directed towards the medial condyle because the medial condyle of humerus is comparatively bigger than the lateral condyle. Okay. Now in dogs you have this supratrochlear foramen. Okay, so this will cause problem in inserting the pin. So always prefer the medial condyle. So direct it into the medial aspect of the condyle. Okay. Radius, majority of the time, because radius is a very narrow bone, and radius and ulna are paid bones, they have a very narrow medullary canals. So usually we do not go for intramedullary fixation. Okay, we either go for a plating or fixation procedures because of the narrow cavity. Because cavity is narrow, we cannot use a larger diameter pin in radius unlike in femur, media, humerus. Okay, we have to compromise on the size of the implant if you use a intermediate pin. Now coming to the simple intramedullary pinning, and this is a single intramedullary pin is indicated in fractures to the length of the bone. A very good implant for transverse or probably even middle third of the long bones. And the advantage of intramedullary pinning because it lies inside the medullary cavity, you can use another ancillary fixation devices like full circular wiring, semicircular wiring, which we have discussed earlier, along with intramedullary. So that is a major advantage of intramedullary pinning. So coming to its biomechanical, this we have also discussed earlier that they can resist the bending forces. They are least sophisticated, and the strength is related to its diameter. So try to use a larger diameter pin, and which should occupy at least 70% of the medullary canal of the long. Okay, that should be your criteria in selection of a size of a pin, and it will resist. It will the ability to restrict the motion the fracture site. Okay, so these are few X-rays I would like to show you where the intramedullary pin is used and it results in a very good fracture. So the pin is directed into the distal fragment. So this is a simple intramedullary pin. Okay. Now the advantage we have discussed of the intramedullary pin is you can use these ancillary fixation devices because the pin will remain inside the medullary canal, and these devices, for example, hemicircular wire is used home. Okay, here we have used two circular wires along with the pin, and the fracture has resulted in a complete union with fracture. What are complications? Because pin, we are putting a pin in a medullary canal. Pin, the cross section of the pin is circle. The cross section of the bone is circle. That means you are putting a circular body in another circular body. Circular body, here is pin. You are putting a circular body into another circular body is medullary canal. Because of that, there are very minimal contact points between the medullary canal and the simple intramedullary. That is the reason why the pin will not remain until fracture healing, and there is a possibility of one complication called migration. Migration means the pin will move from the bone either proximally when the animal starts weight bearing and walking on the operated limb. It will move either proximally or distally, resulting in pin migration. That is one of the biggest disadvantages of the simple intramedullary. Or it can be leading to catastrophic failure. And if you use an undersized pin, suppose as I said, 70% of medullary canal should be filled by the pin you have selected. Suppose if you require a 7 mm pin and you are putting a 3 mm pin, naturally you are not filling with 70% of the medullary canal. So naturally that is prone for bending. So always keep in mind that 70% of the medullary canal should be by this particular. Okay, and we have also discussed that the simple intramedullary pin cannot counteract axial forces. Suppose there is a communicated fracture and you have used intramedullary pinning, there is every possibility that the fracture can collapse. There can be telescoping of the fracture. Okay, so then all these can lead to a delayed union or non. Okay, so these are the failures of. So see here you can see this is a comminuted fracture, and the pin has migrated into the proximal fragment here. Now here there is a catastrophic failure of the implant. The pin has probably again a fall from by the animal. The pin is not holding the distal fragment. Again there is a refracture, and the pin is penetrating the soft tissue. Here there is a again dislodgement of the pin. The pin is not holding the distal fragment, and it has resulted in union in a very bad shape. This we call it the malunion because of the mechanical failure of the plant. So where they are indicated, where their contraindication is when there is a severely comminuted fracture, don't use this implant pin unless and until you have the choice of using a subclass wire or a heavy. We have earlier discussed that subclass wires can be used in addition to the simple, and they are not good systems, good devices to use in the presence of sepsis. Suppose, as I said earlier, classification, we are classified as a open fracture or a compound fracture, simple fracture. Compound fracture exposed to outside environment, there will be possibility that the bacterial environmental bacteria can enter into the medullary canal. So in such cases, it is not a good option to use a intramedullary because you are trying to, you are putting more infection into the medullary canal. Now, as I said, the possibility of migration of the pin is more if you use the single intramedullary pin. The alternative to this is using a stack. Stacking means putting more than one pin into the medullary. Now what happens? Instead of one, there are, suppose you are using two pins. Now the contact points between the medullary canal and the implant will increase because you are using more than one pin. So there is less chance of migration when you are using this stack. Okay. Again, the indications are transverse opening fractures, and we are trying to optimize the torsional stability of the fracture when we are using more than one pin, and multiple pins can be used in extensively comminuted fracture along with the subclass. So the advantage of simple intramedullary pin of using ancillary devices like subclass winding will also hold good for multiple pin. So biomechanics, you are packing the medullary canal tightly with more than one pin, and there are strong frictional forces between the pin and the cortical surface. So it prevents the rotation. So that is the basic biomechanics of using more than one pin. So these are the X-rays which we have done with the help of stack pinning. See, this is the fracture line. More than one intramedullary pin is used to stabilize the fracture. Here also more than one. In addition, we can also use a additional device that is a full subclass wiring along with the stack pinning. Okay, again stack pinning here. All these are femoral fractures. Now, where we should not use this multiple pinning is longitudinal fragments, pin migration or loosening is a complication. And they, like intramedullary pin, if the animal is highly aggressive, migration can also happen with stack. So this is how. So this is again a stack pinning. This is the fracture line, and there is a proximal. So migration can happen proximally, or migration can happen distally also. So this is the fracture line. We are using more than one pin. The pins have migrated distally. Okay, this is one complication. So another modification of these pins of the what we call rush pins. Rush pins means they are nothing but simple intramedullary pins with slight modification at one end of the pin. What we do is we usually turn the one end of the pin towards the cortex of the outer cortex of the bone, so that we are preventing migration of the pin in one direction. Let me show you the X-rays. So usually it does fixation at two different points, rush pins. They are commonly used in pairs. They are never used in singular. So they are used in pair. Because mostly we use two rush pins at one time. So I will show you an X-ray. So this is a typical X-ray. This is the fracture line here. And rush pin is nothing but they cross each other, and they provide 2-point fixation. 1-point fixation is here in the proximal fragment. The other point fixation is at the point of entry. And the distal end of the pin is bent towards the outer cortex of the bone, and this pin is bent towards bent towards the outer cortex. There is no possibility of proximal migration of the pin. Okay, in the spin, there is no possibility of proximal migration. But by chance, if the animal again puts a lot of stress on the bone, there can be distal migration. There can be distal migration, but proximally it cannot migrate. So that's the biggest advantage of brush. Okay, these pins are very contraindicated in young animal, under 4 or 6 months of age, because it will be open, and if you put these pins, there can be damage to the facial plate, and if the facial growth plate is damaged, the animal cannot attain the normal height. It makes growth. Okay, so it results in premature closure of the facial plate, which you have to keep in mind. Another procedure is dynamic intramedullary crossing. Okay, it is regularly used in mature animals, for example, supracondylar fractures or distal fractures of the humerus. It's dynamic intramedullary. Dynamic means because we'll see the mechanism. Here we use 2 pins, and they exert contact at 3 different points. So 1 pin providing 3 points of contact. That means 2 pins, 3 into 2, 6 contact points are provided with this dynamic crossing. So their the advantages are here is they can utilize angular forces, angular bending forces, rotational forces, and torsional forces. So it is better than using the single intramedullary. The procedure is dynamic intramedullary. So this is an X-ray where a fracture is prepared with the help of the dynamic intramedullary pinning. So one pin will be entering from this end. So suppose this is the fracture side, and the pin goes and touches the cortex, and it will take a bend, and it will come into opposite direction. So the point of fixation for this pin is 1, the number 2, and number 3. So if you take 2 pins, again 1, 2, and 3. So 3 plus 3. So there are total 6 points of fixation with the help of this device. Okay, again see another X-ray where it is entering. We are entering from here, touching the cortex, taking a turn, and going up to this level. So this is a 6-point fixation with the help of dynamic intramedullary. So the contraindications for this procedure: comminuted fracture. All comminuted fractures, you have to deal them very carefully because of the possibility of the axial compression when the animal starts weight. Okay. Now KYS means they are nothing but simple combinations of lesser diameter are called KYS, like 1 mm, 1.2 mm, 1.25 mm, 1.3 mm. All these are categorized as KYS. Above 2 and 2.5, we call them as simple combinations. Okay. So the advantage of KYS is they are very elastic, and they can be used in a cross fracture. Suppose this is a fracture in a femur. You got this fracture line here. You can use this KY in a cross fracture. We call them as cross pinning. So what you have to do is you enter from this is the lateral surface of the femur, middle surface of the femur. So you enter with the KY, the lateral condyle cross the fracture line, and exit from the medial cortex. Okay, again medial condyle fracture line, exit from the lateral cortex. So what is happening is, again you are getting a 2-point fixation for 2 pins at the 4-point fixation, crossing each other and providing stability at the distal fractures. Okay, so this we call it as cross pinning. You can use either 2 pins or 4 pins. That means 2 pins from this side and 2 pins from this side. I will show you the example. The procedure is cross pinning. Is very effective for supracondylar fractures, and instead of 2, if you use 4 pins, it provides a better stability. So as I said, it is achieved by 2-point fixation in very distal fractures. 2 pins will provide 4-point fixation. So these are few examples of X-rays, post-operative X-rays, where the KYS are used in cross fraction. Okay, and so see here, this is from the medial condyle, fracture line, lateral cortex, lateral condyle, fracture line, medial cortex. So here 2 pins are used for stabilization. As I said, you can use more than 2 from each side. So here 4 pins are used for stabilization, and this has here also 4 pins, here also 4 pins are used as a cross. Now again, there is possibility because it is not anchored anywhere. There is always possibility of migration and displacement, and it may result in stiffness of the joint because we are not performing. Okay, so this is the dislodgement of the complications after cross pinning. The skin got dislodged, and this has resulted in non-union because of dislodgement of the. These are complications of cross pinning. Now, another procedure which is very important, this we have discussed earlier when we discussed the fracture forces, the tension forces. Okay, tension forces are those which are seen at the point of insertion of the tendons or ligaments, and I have shown you an X-ray of an avulsion fracture of olecranon, avulsion fracture. So this tension band wiring is a procedure which will be used specifically for avulsion, like olecranon, greater trochanter, patella, anterior tuberosity, acromion of scapula, or coracoid of the scapula. So only certain fractures are indicated to be treated with the tension band wiring. Okay. Now this is the basic biomechanics of tension band wiring. So for example, this is a greater trochanter of the femur where tension band wiring is used. This is anterior tuberosity of the tibia where tension band wiring is used. This is the calcaneal fracture of the tarsal joint or the hop joint where tension band wiring is used. So these are different. So this is again a olecranon fracture here. The process is we drive two KYs through the olecranon process, crossing the fracture line into the ulna, and we drill a hole in the ulna diaphysis, and we use the stainless steel wire in figure of 8 fashion, and we create a compression at the fracture. Okay, this is the principle of tension wiring. So biomechanics is here the distractive. We have studied the distractive forces by the pull of the muscle at the point of insertion of the bone. So this is another example. See here, this is the fracture line of the olecranon process. This is because of the pull of triceps here. This has avulsion, and this is reduced with the help of 2 KYs, and we have drilled a hole in the diaphysis of olecranon, and we have used a stainless steel wire in the figure of function, and this has resulted in complete union of the fracture line. Earlier, this is the fracture line. Now there is no evidence of the fracture. So this tension band wiring is particularly important, useful for such avulsion fractures. Now coming to the bone plating procedure. Bone plating again compared to these intramedullary procedure. We have seen so many intramedullary procedures. Bone plating is a further advanced procedure compared to these pinning procedures because it provides a very rigid stability at the fracture site, and we are fixing a plate to the bone with the help of screws. So naturally it provides a better fixation compared to a simple intramedullary pinning. So majority of the plates which we use in veterinary orthopedics have been adapted from human orthopedics, and there are certain specifically veterinary specific plates that have been designed and been used, but the majority of the fractures we use the human orthopedics. So before going in detail to plating, we have to have an idea about different types of screws. Like there are 3 different types of screws, like cortical screw, cancellous screw, and a locky screw. So cortical means where when we use the screw in a cortex, like on the diaphysis, we call them as cortical. When you use them in the spongy bone or cancellous bone, we call them cancellous screws. And if you want to lock the screw with the plate, we use these lock screws. So we go briefly about these screws. Cortical screws are those which are used on the cortex of the bone, hard cortex of the bone. Again, they are used made up of stainless steel, and you get in different diameters, like 1.5 to 6.5. Depending upon the size of the dog, you have to select the size of the screw. Whereas cancellous either they come in fully threaded or partially threaded like this. Okay, they are usually used in cancellous bone or spongy bone, and either you can use a fully threaded or a partially threaded screws. Now, the basic difference between a cortical screw and a concept screw is, this is just to keep in mind, that if you take a unit length of a screw, the number of threads in a cortical screw are more compared to a concept screw. You take unit length, suppose you take a 4 mm length of a screw, so the number of threads in cortical are more in that 4 mm compared to a canceller screw where the number of threads are less. Okay. Now, the other difference is, here you see the canceller screw, the pitch of the screw. Pitch means nothing but the, part that will engage the bone. This will be more in cancellous and less in cortical. Or you can either say that the difference between the core diameter and the outer diameter. So this is the core diameter and this is the thread diameter. So this pitch will be more in cancellous, less in cortical. So that is the basic difference. Why this pitch is more? Because we are using this screw in a spongy bone. Spongy bone is a loose lamellar bone. So you should have more purchase between the bone and the screw. So the screw should engage more bone in a spongy area than in a cortical area. So more pitch is provided in a canceller screw, less pitch is available in cortical screw. So locking head screws, these are locking head screws. Locking head, as the name indicates, the head will also have a thread which will get locked with the some special type of plates which we will see. So these are called as locking head screw. You can see the magnified image. The head of the screw is also having threads, and these threads will get locked with the plate. Okay, indications where the bone screws are used. Apart from plate, they can be used as a latch screw, they can be used as a positional screw, and they can be used as a plate screw. Plate screw is nothing but you fix this plate using these screws over the plate. We fix this. That's the plate screw. Positional screw means, suppose you want to, suppose there is a wedge fracture or butterfly fracture, you want to position it until you do complete fixation. You can use a positional screw, or you can create an interfragment decompression by using latch. So plating, bone plating, simply you can define it as these are the devices that are applied on the bone for the purpose of fixation, and we use screws to fasten the plates on the bone. Basically, we can categorize these bone plates based upon type of holes. Like you get plates with round holes, you get plates with oval holes, you get plates with sliding hole, and there are plates that are used only specifically for certain areas like pelvis, acetabulum, okay, catapult plates. These are different types of plates. And in a oval hole plates, we get a dynamic compression plate, a lock compression plate. We will see one by one. So these are plates with the round holes. Now all these plates are updated. We are using now more advanced plates because there are certain disadvantages in these plates. These are plates provided with round holes where you can fix the screw in only one unidirectional. So that is the disadvantage of this plate. And we get semi-tubular plates again with round holes, and venable plates where there is no constriction between the holes of the plate. So this will occupy more area on the bone, thereby causing reduction in blood supply. Okay. Now, in the earlier days, before the advancement in imaging procedure or the knowledge on bone healing, then they used to think that there should be a compression at the fracture site, and if there is a compression at the fracture site, we call it as rigid fixation. And if there is a rigid fixation, the bone heals by primary healing. Primary healing means without formation of extra careless at the fracture site, the bone should heal without radiographical evidence of the callus. So that was the thought in those days. So people used to do a very rigid fixation at the fracture site. So when you see a radiograph, the bone will be healed, but there is no visible callus at the fracture site. So that was the idea in those days. So they have developed this procedure called compression plating. Okay, so compression compression plates means, as the name indicates, compression, it causes compression at the fracture. Why compression is needed? Well, compression is needed because there should not be gap at the fracture site. If there is no gap at the fracture site, there won't be movement at the fracture fragment. If there is no movement at the fracture fragment, the bone heals by primary healing. If the bone heals by primary healing, there won't be any evidence of callus formation at the fracture site. And that was considered as the best method of attaining a bone healing in those days. So that is why they have designed this plate. We call it as dynamic compression plate. As the name indicates, dynamic means by applying this plate without any external force, this will create compression at the fracture site. Because by using this principle called rolling policy. Okay, we go through this. What actually is a compression plate? So this is called dynamic compression plate or DCP. So they are available in different sizes like 2, 2.7, 2.5. So what this indicates 2, 2.7 is nothing but, suppose I say 2 plate means it will take a 2 mm screw. If I say 2.7, it will take a 2.7 mm screw. If I say 3.5, it will take a 3.5 mm screw. It is neither the numbers, neither the length of the plate or thickness of the plate. Okay. Keep in mind that 3.5 means it will take a 3.5 mm screw. So this is a dynamic compression plate at 3.5. Because I am telling this is 3.5, naturally this will take either 3.5 mm cortical or 3.5 mm cantilever. Okay. This is nothing related to either thickness of the plate or length. Length will vary. Either you can have, now suppose this is an 8-hole plate. We will get a 5-hole plate, 6-hole plate, 7, depending upon the size of the animal, weight of the animal, length of the bone. You have to select the length of the plate. Okay. And this is the middle point of the plate where it should be, this middle point should be exactly on the fracture line. And these 4 screws will be in the distal fragment, these 4 screws will be in the dorsal. And according to the rule of ASIF, you should have at least 3 cortices locked in one fragment. Okay, three screws in each fragment. Suppose this is the 8-hole plate. You can lock these three screws on, or you can lock 3 screws in either of the fragments. So a total of 6 screws can be used. Okay, so minimum is 3 screws in each fragment. So how to fix a GCP? So first you have to select the plate based upon the length of the bone, weight of the animal. Then you have to select the drill sleeve, drill bit. Drill bit means drill bit is to drill a hole in the bone. Then you have to select a sufficient size gap, and then you have to select the size of the length of the screw. Then you, using a screwdriver, you have to fix the screw over the plate. Okay. So these are different types of fractures that can be treated with a bone plating. For example, this is a proximal third oblique, mid shaft comminuted, distal transverse, distal oblique. Okay, so many type of fractures that can be treated with a simple plate. And earlier we have discussed that every bone will have 2 surfaces. One is the tension surface, the other is the compression surface. And plate should always be placed on tension surface of the bone. Never place a plate on the concave surface or compression surface. Otherwise, it will result in bending. See here, the plate is bent after the fixation, which is a failure of the implant. If you put it on tension surface, it will never get. So what are tension surfaces of the bone? For femur, it is craniolateral. For tibia, it is craniolateral. For humerus, again, it is craniolateral. For radius, it is completely cranial. Ulna, it is caudal. And mandible, it is the dorsal surface of the bone. So whenever you are doing the plating, these surfaces of the long bones are kept in mind, and your plate should be kept on these surfaces of the bone. Okay. Sometimes because of certain operational difficulties, we may not be able to put on a tension side, but in majority of the cases, we should place them on the tension side of the bone. And the plate, as I said earlier, if you want to create a compression at the fracture site, it can be used as a compression plate. And the same plate, if you do not want compression, it can be used as a neutralization plate or a bridging plate. So we'll see what actually the bridging and neutralization. If the if the fracture is simple transverse fracture, okay, so for example, this is a simple transverse fracture. Okay, simple transfer. So we are here, this is the medial surface of the bone, this is the lateral surface of the bone, and medial surface is concave or compressive, lateral surface is convex or tension. So plate is placed on tension side. This is a simple transverse, and because you want compression of the fracture side, you can use this plate as a compression. Okay. And suppose there is a two fracture lines, and you do not want compression on the side, you can use the same plate as neutralization. Here we are not creating compression. We are only using the plate to fix the fracture. Here we call it as neutralization plate, and there is a huge loss at the fracture site by multiple fractures. Neither we are using as a compression, nor as a neutralization, but we are only bridging the gap of the fracture. So we are using it as a bridging plate or a buttress. So the same plate, same type of plate can be used as compression, can be used as neutralization, can be used as buttress or bridging. See here, I will give you an example. So these are different types of fractures. We have used the same plate. Here it is a fracture, simple transverse. We have given compression. So this is used for compression plate. Again, a simple transverse radius ulna, the same plate, dynamic compression plate is used for radius ulna. Again, here the same plate, but because there is a combination here, we have used this as a neutralization plate. Plate is same, but the usage is different. Because here there is a huge loss at the fracture site, we are neither using it as compression, neither using it as neutralization. We are using it as a bridging. Okay? So the same plate is put into different uses like compression, neutralization, purpose. And the most unique feature of this dynamic compression plate is the engineering marvel of this gliding pathway of the whole of a plate. Okay, we will see this. We call it as spherical gliding principle. What happens is the hole in the plate is oblong hole, and when you put a screw and you tighten it, the screw will slide over this oblong oval hole, and it will create compression by moving the fragments towards the fracture. So that is a basic idea of a gliding principle. So if you take a cross section of a dynamic compression plate, the hole will look like this. See this you are seeing here, this slanting hole here. The rest of the hole is normal. Only one side of the hole you have this slanting surface. When you use this area and you drill a hole and you apply a screw, when you tighten the screw, the screw head will slide over this slanting surface, and it will, this movement of the screw head will cause compression of the fracture. And to create that compression, we have to use a device called as a drill guide. Drill guide means an instrument used to help in drilling the hole on a hole. So drill guide or drill sleeve, either way you can call it. So in this drill sleeve, you get two color coded ends. One is a green or a neutral, the other one is yellow or loaded guide. Okay, if you want to use a compression, you should use a loaded guide. If you want to use the blade as a buttress or neutralization, you should use this neutral guide. That is the basic difference of using a blade as a compression blade or a neutralization. If you want to use it as a compression, you should use a loaded guide. If you want to use it as a simple or neutralization blade, use a neutral guide. And the basic difference between a loaded guide and the neutral guide is the position of the hole in the guide. So this is a guide here. We are using this drill bit to drill a hole through the guide here. So if you use a loaded guide, you will be drilling the hole eccentrically, not exactly at the center. See here, this is a loaded guide. We are drilling a hole. Hole is created not exactly at the center of the plate hole, eccentrically of the plate hole. When you use this neutral guide, where the hole is in the center, when you drill a hole, you will be drilling exactly in the center of the plate hole. So that is how the basic engineering is provided for creation of compression. the hole in the center will be drilled exactly in the center. When you apply a screw, nothing will happen. The screw will be fixed along with the plate to the bone. This is in a neutral mode. When you do it the same in a loaded guide, when you want compression, you are not drilling the hole in the center. You are drilling the hole in the eccentrically. Now you are fixing the screw. The screw is this is the plate and this is the bone. Now the screw is being fixed. When it reaches the head part of the screw, it will slide down the hole of a plate and it will move in this direction, bringing the fragments closer towards the fracture line, creating a compression. Creating a compression. This is how compression is created. So screw placed in compression mode in this. So this is how the sliding ball principle. When the ball slides through the oblong area, so this is the head of the screw. See this slanting oval line of a plate. So when you are drilling eccentrically with a loaded guide, when you tighten the head of the screw, it will fall in this oval shaped oblong hole, and it will create compression. So that is the basic engineering in the DCP. Here how it slides. So now see this is the fracture line. First hole you have drilled with a loaded guide, and it has created second movement. Now second screw you are tightening, then it causes compression, and it will. So ultimately, when you apply three screws, this fracture gap you see here has been completely reduced, and you have created compression at the fracture side. Now, because by application of plate itself, you are creating compression at the fracture side. This is called dynamic compression. Now, if the fracture is stabilized in this position, there won't be any callus formation, and it will heal by primary healing, which will happen very early than a callus formation. Okay? Now, this is pre-stressing is nothing but to give a shape to the bone plate before it is applied to the bone. So, according to the plate contour, the plate is bent and then it is applied over the bone. So, these are stages of healing. So, there is some fracture treated with the dynamic compression plate, and see without any callus here, the fracture has healed, no exuberant callus, because we have given a compression at the fracture side. So, this is how a plating with DCP will occur. And this is how the animal starts weight bearing on the operated limb. Advantages are you can get very near normal anatomical position, no callus evident at the fracture site, basic fixation. Animal comes to uh, weight bearing very early. But only disadvantage is stress protection. Stress protection is nothing but whatever area of the bone covered by the plate will be devoid of blood supply. So because there is devoid of blood supply, that part of bone becomes weak, osteopenia will be there, and it will result in osteoporosis and weakening of the bone. So that is the one disadvantage. So to counteract this advantage, they have developed another type of dynamic compression plate where what we call limited contact. What is the difference in a limited contact is if you see the upper surface of the plate is same, but under surface there are cuts that are being provided so that there is a possibility of blood vasculature to develop under this plate. So the under surface of the plate is like this. So this will have limited contact on the bone so that the problem of osteoporosis is withdrawn. Okay. Now, now another type of plating is the locking compression plate, where I have shown you the screws earlier with the locking head. So this locking screws will be this plate will have a combi hole. One hole will be like a normal dynamic compression plate. Another part of the hole will have threads where the screw will come and will sit in this plate, causing complete locking of the screw with the plate, providing better stability. So these are further advanced plates over dynamic compression plates with a combi hole called as locking compression plates. So these are locking compression plates. See, this is a threaded part of the hole. This is a non-threaded part of the hole, and this threaded hole, threaded screw will go and engage the threaded part. If you want to use a non-locking head screws, you can use a non-locking. So these are locking head screws, which I have shown you earlier. So this is how a locking compression plate is used. Again, it will come with a 3.5 locking compression plate with a combi hole. We can use this threaded select a plate, drill a hole with a drill bit, then select a screw, a screwdriver. Okay? This is how the locking compression plate is fixed. So this is one case study for you. This is a distal radius on a fracture, which is repaired with a locking compression plate. You can see all the screws are locked along with the plate, providing better stability. So when locking compression, normal compression, you will have complete contact between the plate and the bone. Where locking compression, you will have this much area where the blood vessels can develop and the bone will not undergo any osteoporosis. So the problem of stress protection is not there with the locking compression. So these are the second exercise, which the locking compression. You can see the gap between the plate and the bone. So this gap is utilized by the blood vessels for supply of the blood, so that there is no problem of stress protection. This is how the animal walks. Okay, and if there is smaller fragments, for example, this is a very small distal fragments. So what is the alternative? So for that, there are available the second plates are available. We call them as locking compression T plate, where there is a T-shaped area of the plate which is used for the distal fragment, and you can lock these screws, and this is for the shaft of the bone. These are called locking compression T plates. So these are locking compression T plates. See, this is a very distal fragment. So if you use a normal plate, we cannot have three screws here to be fixed in the distal fragment. So if you use a locking compression, so because of the presence of T part of the plate, we can get three screws in the distal and normal four screws in the proximal. So this is the advantage of, particularly for the distal third fractures or proximal third fractures, locking compression T plates are very important. So this is again a distal third radius terminated fracture. A normal plate, hardly we can have two screws, which is against the rule of plating. So if we use a T plate, we can have at least four screws in the distal and 4 or 5 screws in the proximal. So this is a complete healing of the bone of a distal femur fracture using a locking compression T plate. This is how the animal starts weight bearing very early. And coming to the indications of plate, when you go, we should go for removal of the plate. Once the implant becomes redundant. Redundant means there is no role of the implant because the fracture is healed. There is no role of the implant. In such cases, you can go for removal. In cases of any implant-related infections, if there is any thermal conduction problem, like in winters, the animal feels pain, it shows signs of lameness, and when the plate becomes non-functional, you can go for removal of the plate. So this is in particular the total scenario of internal fixation involving both intramedullary and bone fixation procedures. And we started with the forces, fracture forces, what are different types of forces, what forces causes what type of fractures. And by seeing an X-ray, we can be in a position to determine what type of forces must have acted on that particular fracture. Then we have discussed about classification of fractures, how to be classified, to have a basic idea on the treatment protocol to be adopted. Then we discussed different types of intermediary pins, their mechanics, their advantages, their modifications, their disadvantages. Then we have discussed about bone screws, bone plates, their disadvantages, advantages, what advancements have taken place in bone plating, and how they are used, what type of fractures, what are the advantages. That part of it also. So thank you very much for your patient hearing. The topic is open for discussion.
Hello. Yeah. Hello. Yeah, Dr. Raghu.
Dr. Arun.
Yeah. So thank you very much for such an elaborate lecture. So which included the anatomy and the biomechanics and different type of techniques for internal mobilization, and especially like biomechanics. Like I was really got a lot of knowledge from your lecture as well. So so I appreciate your efforts. So I invite the participants, if you have any queries, just let me know so that I can entertain few queries, and then I can pass on to Dr. Raghu for the answering. probably Dr. Poonam. Probably they might be later on, probably they might be sending the queries later on. So I'll pass on to you.
Okay, okay.
Okay. So I
Okay,
really,
doctor.
so I'm thankful.
Okay,
So
thank you.
yeah, so I am very much thankful that you have spared your time
Yes.
and gave us such a good knowledge to our students. So thank you very much, Dr. Raghu.
Thank you, Dr. Arun, for giving me this opportunity. I thank NIHEP and GADVASU for giving me this opportunity.
Okay, thanks.
Welcome.